There are lots of integrative ways in which I think about bone health and osteoporosis. The gut bone connection is one of those connections that unfortunately is too often missed in clinical practice. And I hope at the end of this presentation, you'll come away with, at the very least, an understanding that there are probably many of your patients who are not being screened for bone loss, osteoporosis, and fracture risk, who should be. And this will open up those conversations and opportunities to help them and protect them. These are my disclosures, as was already mentioned, so I don't need to belabor that. And why do patients need to be protected? Well, because osteoporosis is absolutely deadly. If you are a woman 65 years or older and you fracture a hip, there's up to a 36% chance that you're going to be dead within a year. There are different studies that have been done. The most commonly cited figure is 20%, but it goes all the way up to 60%. Even at that 20%, it is greater than the 5-year mortality from breast cancer when all stages, SEER stages, are combined. If you survive the first 90 days, the risk for mortality goes down. However, if you are a woman, with osteoporosis, or rather with breast cancer, and you end up in the hospital with a fracture, there's an 83% higher risk that you're going to die compared to a woman with breast cancer who hasn't fractured. And every 30 seconds, somewhere, someone in the world is breaking a bone due to osteoporosis. Globally, it's a health issue that is second only to cardiovascular disease in its impact. Now, for men, the risk of mortality is often cited as being about double that for women. If a man with osteoporosis breaks a hip, the risk for dying is higher. And the thought with that is because the comorbidities as men age tend to be more comorbidities and also more severe, which predisposes them to dying. Someone with osteoporosis and liver cirrhosis going through a hip arthroplasty has a 60% mortality risk and an 80% morbidity risk. And I mentioned the breast cancer mortality with patients who fracture as well. And in patients with GI conditions, there are two things to be, I think, conscious of within the osteoporosis world. And one is bone density or bone loss. That is the most often cited marker that is being treated. People come in with a bone density test, or they get one done, and their DEXA score shows a low T-score, and that is the most common diagnostic criteria for osteopenia and osteoporosis. But that's a surrogate marker. It's just a number on a test. And the real risk is breaking a bone. A bone density test only predicts 44% of women with osteoporosis who will fracture, and only 21% of men. So looking at bone density is I think, an important thing to do, but I don't think it should be overemphasized in terms of its clinical utility. And if that's all people are looking at and just treating that number on the test, instead of thinking more holistically and treating the patient in front of them to fully reduce their fracture risk, I believe they're missing a good opportunity, or the best opportunities, to help their patients. And you can see here that in the general public in the US, adults 50 years or older, this top row, I like summary tables like this, that adults 50 years and older, for women, about 20% of osteoporosis, and any bone loss, we're talking about 43%. For men, about 4.4%. Well, how does that compare in patients with different diseases? You can see with celiac disease, there's not really fracture data that's been published, but celiac disease, up to 60% have low bone mineral density. For acid reflux, GERD, taking a proton pump inhibitor, the absolute odds ratio for hip fracture with long-term PPI therapy, and that's talking, months and years, 350%, 3.49, compared to somebody not on a PPI. And I'm going to review that data a little bit here with the medications. One medication that's not on here that I think is important to understand are the SSRIs and SNRIs. A lot of patients are on those. About 24% of women over 60 are on an antidepressant medication, and SSRIs are the most common category of those. A lot of patients with, obviously, chronic GI conditions, other chronic diseases, where depression is a common comorbidity, are often put on antidepressants as well. Well, now we know that somebody on an SSRI for 1 to 5 years, for anyone taking it for that long, we expect that for every 19 patients taking an SSRI, 1 will fracture. There are serotonin receptors on bone, and they activate osteoclasts. So the problem is you artificially raise serotonin, you're messing with that delicate balance and homeostasis of bone physiology, and it results in bone destruction and increased fracture risk. For IBD patients without surgical intervention, the relative risk for hip fractures, 41% elevated risk for ulcerative colitis patients, and 68% for Crohn's disease. But that, depending on the research, goes all the way up to 278% or 2.78, and on down the line. IBS, liver disease, post-gastrectomy for peptic ulcers, post-gastrectomy for stomach cancer. Let me see if I can get a little laser pointer here somehow. There it is. Here we go. So post-gastrectomy for stomach cancer, primary biliary cholangitis, short bowel syndrome, all increasing the risk. So if bone loss is not on your radar, likely, even if they've come to you and they have a GI doc who is their primary care doc for these issues, they likely have not been screened for osteoporosis. So what are the mechanisms for what I call, enteropathic osteoporosis? I hope that'll become an official diagnosis, but it's currently not. Medications, I mentioned the SSRIs, SNRIs, PPIs, glucocorticoids. A term was coined in 2018 called immunoporosis. It's that chronic immune activation, chronic inflammatory cytokines, which directly affect bone, gut and bone immune signaling interactions. That includes hyperpermeable gut and having particles, inflammatory cytokines and particles going through and entering the circulation. Nutritional deficiencies, quite common in many of these conditions. And then microbial dysbiosis, and then hormones and hormone-like molecules, and that endocrine bone connection. It was celiac disease. Importantly, osteoporosis can be the only presentation of celiac disease. They may not have the neurological manifestations or mood disorder or paresthesias. They may not have any GI symptoms. Osteoporosis can be the only symptom of celiac disease. So if I go through my workup and I've ruled out all the common stuff and it still seems to be a mystery, then I'll consider celiac disease and want to look for that. And the primary mechanisms are pro-inflammatory cytokines, calcium absorption, osteoclast activation. And then, of course, other micronutrient deficiencies are quite important in this picture, as they are with all diseases. Iron, folic acid, B6, vitamin D, copper, and zinc, all documented insufficiencies in celiac disease patients. And in fact, the process with bone loss starts quite a while before probably somebody is diagnosed with celiac. At diagnosis, low bone mineral density in newly diagnosed patients 15 to 35 years old, up to 60% already have low bone mineral density, and up to 35% already have osteoporosis. So if you have a celiac patient who has not been screened for bone loss and osteoporosis, I highly recommend it. Fortunately, in young patients, when they are go on a gluten-free diet and they improve their health, they get this treated properly, the bone mineral density does improve. There is likely to return to normal, but there's just a lack of data for older age groups. Primary biliary cholangitis, how to treat this in terms of treatments and bone loss is not well established. And we see that over and over. The vast majority for the medications in osteoporosis have been conducted on postmenopausal women with osteoporosis, and it leaves all these other secondary causes of osteoporosis, of which there are many. Obviously the diseases I'm talking about are included in that, but you have cancer treatment induced osteoporosis, male osteoporosis. There's just a lack of clinical trial data with the medications in terms of whether or not they're effective at reducing fracture risk. And an interesting aside about those medications is that, back to the bone density story, the change in bone mineral density that all the osteoporosis medications create, the improvements in bone medication, is not an indicator that it's actually reducing the fracture risk. So just be aware of that. Again, that surrogate marker is not as useful as most people think. Most marketing campaigns for the medications have us believe as well. And what also most, I think, clinical guidelines also are lacking that nuanced understanding of the research. So as I mentioned, the majority of the data on, we don't have a lot of data on other conditions besides postmenopausal women with osteoporosis, but the researchers and clinical guidelines will extrapolate from those studies and apply them to different medical situations and conditions. And that's what we have here with primary biliary cholangitis. What we see here is that the mechanism of bone loss in primary biliary cholangitis is very different from the mechanism of bone loss in postmenopausal osteoporosis, as well as the mechanism of bone loss from proton pump induced osteoporosis and SSRI induced osteoporosis, all very different than postmenopausal osteoporosis. So be very careful just prescribing a medication if you are thinking about doing that, assuming that because it's been approved for postmenopausal osteoporosis or it's been shown to be helpful in that condition, that you can just layer that on to another condition. And in fact, there's a great example with proton pump inhibitors, and I'll get to in a moment, where that assumption was tried and failed. But I'll get to that slide in a little bit. The American Association for the Study of Liver Disease, that's the most recent data that we have, or clinical recommendations. They're recommending Fosamax based on the postmenopausal osteoporosis literature, and then screening every 2 to 3 years with a bone density test, plus calcium and vitamin D. But a 2020 review article concluded that the bisphosphonates did not demonstrate any improvement in bone mineral density. Let's forget the fact that they didn't actually look at fractures, but no improvement in bone mineral density compared to no intervention or placebo. Overall, the quality of the evidence is low. And we see that over and over again, where these clinical guidelines are coming out and the quality of the evidence is low. They're uncertain. The ratio, the benefits and the doubts are uncertain, and yet they're still recommending the drugs despite that as first-line therapy. What we do have is some clinical trials as we go through of some nutrients. MK4, it's a specific form of vitamin K2 for some of these conditions. Primary biliary cholangitis is one of them. It was a randomized controlled clinical trial with 30 patients over 24 months. They were given 45 milligrams daily of MK4, no MK4. They all also received ursodeoxycholic acid, 600 milligrams a day, and the primary outcomes were bone mineral density changes. And what we see is that at 12 months, the treatment group improved, statistically significant improvement in bone mineral density compared to the placebo group or the no intervention group. And at 24 months, still significantly higher bone mineral density in the group of patients taking the MK4 compared to the no intervention group. Post-gastrectomy for stomach cancer, what we see is that osteoporotic fractures occurred a median of 3.1 years after a gastrectomy. And in a large study, 15% of those fractures were multi-site fractures. And you're talking primarily also in the elderly and chemotherapeutic patients. So like I mentioned before, comorbidities increase the risk of mortality. Well, they also can increase in different situations. If there have been other treatments that have happened, like chemotherapy patients, they can have you get an increased risk in fractures as well. And obviously, just being older is a non-modifiable risk factor for both osteoporosis and fractures. So significantly associated with osteoporosis, you can see here, older age, female, total gastrectomy. And then with fractures, though, not the same. There's not a complete overlap. Diabetes, older age also, female also, total gastrectomy, but chemotherapy. So having other comorbidities and history of other treatments, medication treatments as well. So the American Gastrointestinal Association 2003 recommendations, it's the most recent recommendations we have. There's no difference in risk in terms of osteoporosis In terms of acid-reducing procedures, no apparent risk in the absence of gastrectomy. So if there's a vagotomy, they don't believe there is an increased risk for osteoporosis and fractures, and no difference in the risk in post-gastrectomy depending on the procedure type. So total versus partial gastrectomy, any type of procedure increases the risk. And again, they're recommending bone mineral density measurements, calcium or bisphosphonate supplementation after at least 10 years, which is odd for me since we see here the median fracture occurrence is 3 years after gastrectomy, and they're saying wait for 10 years. So it doesn't make sense to me. If anybody has a good explanation, I'd love to hear it. Bariatric surgery patients, we'll see with GLP-1s how much business is lost for these surgeons, and how low these procedures get, the decrease in those procedures over the coming years. But from 2022, in 2022, there are about 280,000 of those surgeries. The most common was the vertical sleeve gastrectomy, followed by Roux-en-Y, and then revision surgeries. And what we see is that no matter which type of procedure, they end up with a risk of bone loss. So just 1 year, and not just bone loss, but nutritional deficiencies. 1 year after bariatric surgery, about 71% of patients had vitamin D deficiency. About 21.5% had iron deficiency. And you can see the list here. I can tell you of the patients that I've had come to me who have had bariatric surgery, not one had been recommended nutritional support or had serum ferritin tested or routine monitoring of their vitamin D levels. And so, it's been a while since I've worked with patients who have had this. Hopefully that's changed. But my experience is that this is a population walking around at risk that is being poorly counseled by their surgeons and needs some additional integrative help to ensure that they are protected, and not just against osteoporosis by ensuring nutritional deficiencies are corrected, but of course, all the other problems and diseases that occur because of nutritional deficiencies. And what we see, though, beyond just the nutritional effects, that hormone disruptions occur after bariatric surgery. So leptin decreases, leptin inhibits osteoclasts. So when you have leptin going down, you have an increase in osteoclast activity and you get increased bone loss. And so elevated higher leptin is associated with bone mineral density in human studies. And this is one of the mechanisms explaining why you get bone loss in patients after bariatric surgery. And then peptide YY increases. That also is a satiety signal. And when it's reduced in obesity and increases after bariatric surgery. And it's a negative regulator of bone formation. So essentially, as PYY goes up, bone formation goes down. The clinical guidelines, no data on the use of anti-resorptive agents, specifically for the management of bone loss resulting from bariatric procedures. That includes bisphosphonates and denosumab, or any of the other medications for that matter. You can get a secondary hyperparathyroidism, hypocalcemia, vitamin D insufficiency, and those need to be effectively managed when starting anti-resorptive agents or a bariatric procedure. Now, that's interesting. I think they should be effectively managed even without anti-resorptive therapy, but that's the 2019 clinical guidelines that were for perioperative nutrition that were released by the American College of Endocrinology and the American Association of Clinical Endocrinologists. I think they're missing some big opportunities here to help patients, but this is their conclusion. Irritable bowel disease and bone loss can be the predominant or primary sign of IBD in children and adults. The principal mechanism still not completely understood, but it's a complex network, just like with all of these conditions with inflammatory cytokines that influence bone destruction, and that has been reported. Also, the etiology includes genetic factors, although that is really a squishy area for me scientifically. There are so many genetic potential factors at play here. I've never seen any conclusive evidence that genetic factors are the primary driver in this situation, and in the vast majority of, or I would say all bone loss in adults. Obviously, in young children, that can be a a bigger driver. But in adults, I've yet to see any compelling information that except for maybe a very small minority of patients, that it's primarily genetic driven. Medications are an issue. Chronic inflammation, I sort of mentioned all of these before. IBD bone loss and fractures, prevalence of osteoporosis up to 77%. Odds ratio of fractures 32% compared to patients without IBD. And just for a hip fracture, the most dangerous type of fracture, that's the citation. Those are the numbers that were cited in the summary table towards the beginning of my presentation. 41% relative risk of hip fracture in IBD ulcerative colitis patients and 68% in Crohn's disease patients. Current steroid use is associated with a reversible 35% increase in hip fracture risk. And if somebody is on one or more opioid medications, that gives a 67% increased risk. What we do know with the glucocorticoids is once patients stop taking chronic glucocorticoids, that the bone density will improve, but we never know if it goes back to its baseline. The other thing to be aware of with glucocorticoids is that the risk for fractures occurs before bone density loss. Bone mineral density will decline on a DEXA scan. And one of the reasons for that is because the glucocorticoids, prednisone, dexamethasone, et cetera, damage bone collagen. They not only decrease its production, but the collagen that is there, they make it stiffer and more friable. And it's the collagen in bone that gives bone its ultimate strength. It's one of the explanations why bone mineral density is such a poor predictor of fractures. And so that collagen destruction with the glucocorticoids, it will increase the risk for fractures before you get a decrease in bone mineral density. It also damages muscle microfibrils, which increases the risk for falls. 95% of fractures occur because somebody falls. So, anything we can do to reduce the risk of falling can reduce the risk of fractures. And another sort of aside during my talk is that importance of falling, of strength, balance, stability cannot be underestimated. It is crucially important to focus on that. There was a study that was done that looked at the ability of a bone mineral density test to predict fractures as combined with whether somebody was strong and stable, or if they swayed and they have low stability and were at a higher risk of falls. And what they found is that when fall risk was reduced, when somebody was strong and stable, the ability of a bone density test to predict fractures went down to 5% in women and a little bit lower than that in men. So be aware of that when you're thinking holistically. The principal mechanisms behind reduced bone mineral density in IBD patients are still not completely understood. Again, it's a similar picture over and over. Medications, chronic inflammation, nutritional deficiencies. Here are the nutritional deficiencies common seen in IBD patients. You see the vitamin K, 43.7% of ulcerative colitis patients and 54% of Crohn's disease patients deficient in vitamin K. And just as an aside, because I mentioned MK4 already, with respect to bone health, there are two primary vitamin K2 molecules that are commercially available. Vitamin K2 is a category of vitamin K2 molecules called menaquinones. MK4 and MK7 are the ones that you're probably familiar with commercially. And all forms of vitamin K, including vitamin K1 and MK7 and other menaquinones, they're all converted into MK4 in the body. MK7 is produced by gut bacteria, whereas MK4 is produced by mammals, including us, through the UBAD1 enzyme. And MK7, if you look at the clinical trials with MK7 and all doses that have been studied, it's never been shown to stop or improve bone density, stop bone loss or improve bone density. In one study, in fact, the women taking the MK7 had faster rate of bone loss at the hip. There are no fracture outcomes data for MK7 using MK7 clinically, none. MK4, there were 25 clinical trials repeatedly shown, as I showed you in the primary biliary cholangitis clinical trial, to stop bone loss in different caused by different medical conditions, also from medications, like glucocorticoids and androgen deprivation therapy in postmenopausal women with osteoporosis, not only to improve bone density consistently, but more importantly, to reduce fractures by more than 70% in some studies. It's been so well studied that MK4 has been approved by the Ministry of Health in Japan in the dose of 45 milligrams per day since about 1995, maybe it was 1996, for osteoporosis and bone pain caused by osteoporosis. So we were talking about the clinical trials. Dr. Nori, I'm sorry if I'm pronouncing your name incorrectly. I apologize. At the beginning was talking about the types of adaptogens. Well, similarly, when it comes to different nutrients and vitamins, they do have some overlapping activity. The types of vitamin K, like a Venn diagram, but they also have very different activities because they're different molecules. Similar with vitamin E, it's a category. The tocotrienols and the tocopherols and the different even types of tocotrienols, they don't have all the same activity in the body. So the specificity is very important when it comes to clinical trials and wanting to work with nutritional medicine and nutritional approaches with supplementation with patients. Those details, I think, are crucially important. So treating GIO, glucocorticoid-induced osteoporosis, 2022 guidelines from the American College of Rheumatology. Like I mentioned before, low certainty. All evidence for preventing bone loss was low or very low. The recommendations are not based on clinical trials showing medications prevented fractures because most studies only evaluated changes in bone density, and most recommendations they had were conditional, uncertain benefits and harm. What we do see for first-line therapy they're recommending is oral bisphosphonates like Fosamax. And when you look at the studies on that, the first systematic analysis was published in 2018, and it showed that it increased bone density but did not decrease fractures over any time period all the way up to 24 months. Prolia, first meta-analysis, was published in 2019 for glucocorticoid-induced osteoporosis. Similarly, bone density went up, but it was underpowered to detect fractures. No meta-analysis exists for Forteo, but it may be more effective than Fosamax, but we just don't know. There are clinical trials with MK4 and glucocorticoid-induced osteoporosis, 45 milligrams per day. The patients were also taking prednisolone, and they had a tapering dose of that over approximately 6 weeks. And this was a prospective randomized 10-week study. And the outcome was bone density, not fractures. But what we did see is that MK4 preserved the bone density. There's no significant change in bone density, whereas glucocorticoid only group had a significant decrease in lumbar bone mineral density. The second clinical trial, patients with different kidney diseases, IgA nephropathy, minimal change disease, et cetera, 60 patients were on glucocorticoids. There was a control group that all they had was they continued their glucocorticoids, some just vitamin D as alpha calcidiol, MK4 group, a combination of D plus K, and then all patients also took the prednisolone. The result is what you see is that there's no significant changes in bone mineral density in any other group except for the control group. Control group had a significant decrease in bone mineral density, so just taking the prednisolone alone. What you saw is in the vitamin D plus K group, you had a improvement in bone mineral density, and also in the vitamin K group, and also in the vitamin D group, and that's vitamin K as MK4. And the group D, though, group D was the vitamin D. The group D significantly increased from 9.59 to 10.2. In all other groups, there was no significant changes. So group D did have significant changes. This is a little bit in serum calcium, not in bone mineral density. So even though the serum calcium went up, if it was just with vitamin D alone, if there was vitamin D combined with quinone 4 or MK4, serum calcium did not increase. Acid blocking medications, not only can they create nutritional deficiencies, but they can also create intestinal dysbiosis. 50% of PPI prescriptions are written for just one condition, GERD. GERD can be treated very well frequently with just some dietary changes, integrative approaches. So if we can avoid even prescribing those for GERD or get people off them, that's a fantastic thing. This is not new information. The FDA sent out its first its warning letter in 2010, which warned against the PPI-induced risk of fractures. And one of the earliest studies that came out in 2006 in JAMA that showed an association of the crude odds ratio, even just after 1 year of PPI use, was 85% higher than patients not taking it. And the adjusted odds ratio, even still, 44% increased risk. Even for H2RA, histamine 2 receptor antagonist, you still had an increase ratio, absolute odds ratio of hip fracture of 23%. And that's something that's actually, I think I've seen missed. I've had patients who are on PPIs, who are not my patients, but they're on PPIs, and I pointed out the risk, and that's probably what's causing or contributing to their osteoporosis. And I've had their doctor just want to switch them to an H2RA medication. And if you have to be on one, that does seem to be a safer alternative, but it is not completely safe. And that is, patients often are not counseled about those risks. Like all medications, the longer the duration, the higher the risk, the higher the dose, frequently, the higher the risk as well. So 4 years of taking PPI use, you got an odds ratio of 2.17 or 217% increased risk. The PPI-induced hip fracture risk was stronger in men than in women. And when it was restricted just to patients with GERD, you've got almost 350% increased risk for hip fracture. However, in patients with GERD, H2RA use was not significantly associated with increased fracture risk. So you can see with this confidence interval, there actually are patients where it is increasing their fracture risk, but overall, it was a non-significant increase as a group. But be aware of that. H2RA may be safer alternative, but it is not without risk. What about fall and fracture risk? As I mentioned, 95% of fractures occur because somebody falls. So PPI use was significantly associated with an increased risk of falls compared to volunteers not on PPIs. And in patients using a PPI, the risk of falling that then resulted in them being hospitalized was significantly greater compared to those not taking proton pump inhibitors as well. In contrast, there was no significant association with the H2RA medications, Tagamet, Pepsid. So again, the H2RAs appear to be a safer alternative. Now, this is a story of deciding that a medication works in one patient population, so I'm just going to use it in another patient population. And this is a cautionary tale because bisphosphonates are FDA approved for postmenopausal with women with osteoporosis. Doctors started using them for other types of osteoporosis, like PPI-induced osteoporosis. Well, they decided to study that assumption, the assumption that it would work. And not only did it not work, but it was tragically increasing fracture risk. So meta-analysis of 4 studies, there was increased fracture risk in patients taking the PPIs plus the bisphosphonates compared to only taking bisphosphonates alone. So those taking a PPI with a bisphosphonate, they had a 52% increase in fracture risk compared to just taking the bisphosphonate by itself. And there was no significant difference in fracture risk when patients taking different types of bisphosphonates, meaning it didn't matter that the type of bisphosphonate, all of them resulted in increasing the fracture risk in these patients. To date, no published clinical studies evaluating the use of PPIs with different other categories of osteoporosis medication. So we don't know, again, the danger of just, taking one mechanism of action or one patient population and doing off-label prescribing when the mechanism of actions for the underlying disease are totally different. Osteoimmunology, so cytokines, pro-inflammatory or osteoclastogenic cytokines. You've got tumor necrosis factor alpha, IL-1, 6, 7, 8, et cetera. Those promote osteoclast differentiation, not just that there are more osteoclasts around, but they live longer. And so they can do more damage. And essentially, osteoporosis is a disease of imbalance. You have to have a healthy balance of bone-building osteoblasts and bone-destroying osteoclasts for healthy bone remodeling. And when that balance is not healthy and you get too much osteoclast activity, of course, you're going to get bone destruction going on. Anti-osteoclastogenic cytokines, interferon alpha, interferon beta, interferon gamma, different interleukins. Those all down-regulate the osteoclast differentiation, survival, and proliferation. And you can see here in this, cytokine networks and irritable bowel disease progression, you've got this homeostasis here on the left, where you have, macrophages with IL-10, IL-18, doing different, cytokines. And then when you get initiation and progression and T helper cell differentiation, more inflammatory cytokines being produced, you've got bone destruction going on, because what happens with ulcerations, or when there is hyperpermeable gut, you're going to get these cytokines entering into the systemic circulation, and they can travel then to the bone, where they directly affect the bone. You can see here the blood vessel here. And what happens is you get that direct interaction and that network between the gut and bone. And you can see here how it affects differentiation. If you just want a nice visual here to help you, you have the mesenchymal stem cell here, and you have IL-17, tumor necrosis factor alpha, rankle, and those are all stimulating osteoclast differentiation. And then you have your TLPR1, TLPR2 cells, interferon gamma, IL-4, all blocking osteoclast or decreasing osteoclast differentiation. And that got me thinking, well, if tumor necrosis factor alpha over here on the left is pro-osteoclast, what about anti-TNF alpha therapy? Could that help? And so I started looking at the research, and there's, lo and behold, some studies out there. A clinical trial with infliximab 5 milligrams per kilogram in adults with Crohn's disease. They looked at lumbar bone mineral density. It did increase by about 8% compared to controls. No significant difference in the hip bone mineral density. By the end of the study, though, there was no significant difference between the treatment group compared to the control group in patients taking prednisone. So it didn't completely counteract, or did not counteract the deadly effects on bone that prednisone has. But in a second clinical trial here of patients with Crohn's disease taking prednisone, same dose of infliximab, 5 milligrams per kilogram for a year, you did see an increase in bone mineral density of the lumbar spine and the femoral neck. If it had gone on like the other one to 22 months, would that bone density have decreased again? I don't know, but we are seeing some good clinical improvements in bone density. And as I've mentioned, several times, bone density, it's a surrogate marker. If we can improve it, I think we should. It does have some utility in terms of predicting fracture risk, but it definitely should not be the only thing that we are focusing on. Gut permeability, I've mentioned a few times here, and the intestines control that molecular trafficking, between the lumen and the epithelium submucosa through the paracellular space. The gut-associated lymph tissue, it is the largest immune tissue in the body. And under physiological conditions, molecules less than or greater than 15 angstroms do not cross through that intestinal wall. But when you have increased permeability, you have an increased range of molecules. Larger molecules can get through there. That increases the potential antigenic load entering the epithelium, submucosa, which then activates the systemic pro-inflammatory responses. And that's the underlying mechanism, or one of them, by which you get that bone loss occurring. You also get osteoclastogenic cytokines produced by immune cells. So as I mentioned, those interleukins, those pro-osteoclast interleukins from the intestinal subepithelial mucosa that then enter the systemic circulation. So any change in gut permeability can elevate levels of osteoclastogenic cytokines and decrease bone density. Microbiome effect. This is an interesting area of ongoing research, which I'm excited about. But to date, I'm a little underwhelmed by not only the research and the studies in terms of whether or not repopulating the gut or with probiotics or supplementing with probiotics can actually improve bone health. And I'll review some of those studies here in a moment. And this goes back to my pet peeve with the dietary supplement industry is these supplement companies are making a lot of claims out there, and you've got to be really careful and ask the right questions to ensure that they've actually been substantiated with clinically relevant or clinically relevant outcomes. And the MK7 is a great example of that. You have companies that are selling MK7 containing dietary supplements for bone health, and they talk how it improves undercarboxylated osteocalcin, or it can help promote or support bone health or bone physiology. What you'll never see is that where they say is it actually improves bone density or maintains strong bones as indicated by fewer fractures in clinical trials. And that's because it's never been shown to do either one. So I think becoming savvy consumers, understanding the questions to ask that are most clinically relevant, teaching our patients how to ask those questions is one of the things I'm very passionate about doing. And I go through that, over and over in my book, questions that people should ask of supplement companies, of their doctors, because asking the right questions is going to help people make better decisions. And it's going to help all of us as clinicians counsel our patients more effectively. So what we have here is gut microbiota is associated with physiological bone metabolism, again, through inflammatory or with metabolic bone diseases and inflammation. Most of the studies are in mice, and they indicate that the gut microbiota, it is a major regulator of bone mass, not just a regulator, but a major regulator. Vitamins derived from the microbes in the gut, those bacteria in the gut, are potential regulators of bone matrix quality. So the bacteria in the gut, healthy bacteria, will produce vitamins for us, B complex vitamins, also short chain fatty acids like butyrate, propionate. Those are all important for bone health as well, and modulating inflammation. Microbiome is associated with systemic hormone regulation as well, including IGF-1, an increase in T cells in the intestinal wall that then migrate to produce increase in rankle, which then affects bone and affects bone by increasing bone breakdown. And that's what denosumab is. It's an anti-rankle. So this is actually looking at alveolar bone, and I think that's a common area that's missed in our evaluation, or people's evaluation of patients, is bone health, and asking about, do they have gingivitis, because alveolar bone loss can be an indicator of more systemic problems going on. And here you just see a nice drawing of how down here gut microbial dysbiosis can go leak through the gut epithelium. It can get into the circulation, activate these dendritic cells, activate the immune cytokines here, Th17, TL17, which then increase osteoclast precursors via rankle and bone breakdown, and also then going to the bone and also affecting the alveolar bone here internally as well. And how healthy short chain fatty acids produced by healthy gut bacteria can actually block this process from happening, as well as estrogen, which is anti-inflammatory and inhibits osteoclast. Another side note, estrogen, when estrogen goes down, estrogen is important for the gut absorption of MK4, vitamin K, all forms. And so when estrogen goes down, you also can get a decrease in MK4, vitamin K absorption. As another aside, the nitrogen-containing bisphosphonates, second-generation bisphosphonates like Fosamax, they block the production of MK4. So there's all this data out there about MK4 not only improving bone density, being important for bone health, but a lot of other processes in the body, but also reducing fractures. And the Fosamax second-generation bisphosphonates actually block our own production of the MK4, which I believe just compounds the problem. Microbial bone effects here. I talked about a lot of this. The challenge is looking at these studies is, while there is mounting evidence linking changes in the gut microbiota to the pathophysiology of osteoporosis, the studies are all over the place. So in terms of whether it's a single strain probiotic, multi-strain probiotic, the duration of the treatment, and there does seem to be a duration effect as well. And that heterogeneity of studies makes it difficult to identify the correct, the most beneficial bacteria in the doses and the duration that can be most helpful for bone health. Gut alveolar bone axis, I talked about this. So patients with GI diseases You can see them all here. They have altered oral microbiomes, enriched what are called pathobionts, organisms that can cause harm under certain circumstances. So here are all the families here of those bacteria, and those contribute then to periodontitis and alveolar bone loss. So it's not just dysbiosis in the intestines, but also the mouth microbiome is important as well. Talked about this. We do see dysbiosis in patients with osteoporosis, and mounting evidence is linking those changes in the gut microbiota to the pathophysiology of osteoporosis. I talked about this in the last slide. So there's a lack of human studies. So all data below are drawn from mice studies. And I did a review of the research before, today, recently, to see if anything more recently had been published. And I'm just very underwhelmed by the studies and the research. And so all of this is still accurate. What we see is that it prevented alveolar bone loss in rats when they were fed. We've had fermented milk containing Lactobacillus helveticus. They had higher bone density than in controls in terms of the rats. When Lactobacillus rudii that increased bone mass by decreasing bone resorption, but only in male mice, not in female mice. Follow-up study improved bone density in female mice, but only after surgical stress to induce pro-inflammatory state. So, what is the physiological environment that is going to result in improvement in bone density or preservation of bone health or improvement in bone health when you prescribe or use a probiotic? And is it low estrogen? Is it when there's inflammation, without inflammation? All these questions, because it's such a multifactorial process, are feeding into this confusion of what might work and when. And another study showed that Lactobacillus rudii 6475 prevented bone loss in mice without their ovaries. Lactobacillus fermented soy milk prevented trabecular bone loss just as effectively as as alendronate, Fosamax, in an animal study. Two controlled studies with 10-week-old mice. So one used a single strain, Lactobacillus GG, the other multi-strain probiotic. Both had the same results. Both prevented bone loss. Both reduced gut permeability, and both reduced systemic inflammation. Both formulas increased bone mass in estrogen-replete mice by increasing osteogenesis. So, you can definitely recommend this, but to say that the case is closed and we know exactly the combination that's going to work in these different situations, I think it's a little premature for that. But the bottom line is, if there is dysbiosis that is there, working to correct that, I think is very important, not only for whatever GI condition is there, but also for bone health. Short chain fatty acids in bones, they affect bone metabolism. Feeding mice short chain fatty acids in a high fiber diet increased bone mass, decreased bone loss, and improved osteoporosis. That's without providing a probiotic supplementation, just fiber, just the prebiotic, improving the fiber. Butyrate is increased osteogenic osteoblasts, increased osteoblasts, increased mineralization, increased alkaline phosphatase, increased osteoprotein, OPG, which decreases osteoclast activity and decrease osteoclastogenesis. Propionate, also beneficial for bones, decreases osteoclast. And short chain fatty acids, they reduce the intestinal pH, and that allows people to improve their calcium absorption. Mediterranean diet and irritable bowel disease. So patients with IBD tend to have less bacterial diversity, lower numbers of Bacteroides and Firmicutes, which contribute to decrease butyrate production. Mediterranean diet, which is primarily a plant-forward diet, so lots of fiber, mixture of vitamins and minerals and other plant nutrients, stimulates Bifidobacter, Lactobacilli, Eubacter, you can see them here, all these different beneficial bacteria. And people who adhere to a greater degree to the Mediterranean diet were shown to have increased levels of fecal short-chain fatty acids, Prevotella and Firmicutes. Low adherence associated with TMAO, which is associated with irritable bowel disease. So meta-analysis showed that the higher adherence to Mediterranean diet is associated with a 21% decreased hip fracture risk, and higher bone mineral density in the lumbar spine, whole body, and trochanter in postmenopausal women with osteoporosis, to be clear where that came from. Here are the components of a Mediterranean diet and their health effects in different GI conditions. So gut homeostasis, you can see all these here for time. I'm not going to belabor the point, but what they all do is they help to repair leaky gut. They help to modulate, improve, and decrease inflammation. They increase beneficial short-chain fatty acids and decrease opportunistic bacteria. So these are, and these are the different ingredients or within the Mediterranean diet and those effects here in the liver disease, for example, and the different possible mechanisms. Protein is something that is commonly overlooked. I think it's having its moment. There's a lot more light being shined on protein and the need for protein. The USRDA for protein for bone health and healthy muscle mass and strength is inadequate as we get older. 0.8 grams per kilogram body weight per day is not enough for people as they age. Bone is a highly protein dependent tissue. There are 180 to 200 different proteins in bone in addition to collagen. And so making sure that you've got enough protein is important. There's a European position statement that the amount of protein that somebody consumes, that alone can account for about 2 to 3% of bone mineral density, just the amount of protein. So clinical trials have been done and just consuming the USRDA of protein, 0.8 grams of protein per kilogram body weight per day, resulted in a decreased mid-thigh area, muscle area, over 14 weeks in the volunteers. And obviously, sarcopenia is a risk factor for falls, which of course is a risk factor for fractures. So research suggests a minimal protein intake of 1 to 1.3 grams per body weight per day. Some suggestions go all the way up to 2. I like as a minimum, if somebody takes their body weight in pounds, because we don't do kilograms here in the US, and multiplies it by 0.6, that's the floor. That's the minimum amount of protein somebody should be consuming during the day. The other thing to be aware of is the pattern of consumption throughout the day. As people get older, they tend to consume their protein primarily in the latter part of the day around dinner time. And it's important, the research is showing that it's important to consume it earlier in the day where you can get more benefits through exercise and getting that protein uptake occurring. So consuming your protein more earlier in the day, not stacking it at night, is a recommendation that I give to patients. Here's that consensus statement. I was actually wrong. I said 2 to 3% of bone mineral density. It's actually 2 to 4% of bone mineral density. And they're even saying the current USRDA recommendations are ineffective or not enough. And they also do recommend exercise and calcium and vitamin D. Protein and all-cause mortality, not specifically in GI patient populations, but in general, what we see here is total protein is associated with a decrease in all-cause mortality. And plant protein, there's an inverse dose response between plant protein and all-cause mortality. So an increased 3% from plant proteins was associated with a 5% lower risk of all-cause mortality. So both plant proteins by themselves or just total protein, it doesn't seem to matter the source for mortality. However, vegans and vegetarians are at higher risk for osteoporosis than omnivores. Not all studies showed that, but most of the studies show that. And the thinking is that in the vegans and vegetarian studies where there was an increased risk of osteoporosis and osteopenia, the problem with this, the dietary intakes in those patient populations is that they weren't getting enough protein. It's harder to get that higher quantity of protein that's recommended from a vegan and vegetarian diet. It's not impossible, but please just be aware of that. I actually have patients calculate their protein intake over a couple of days, as well as their fiber intake, because I want them to get at least 30 grams of dietary fiber per day without changing anything. So calculate how much total protein, how much total fiber they're getting over a couple of days. And then we calculate based on their body weight, what's the minimum amount of protein they should be getting. And then a minimum amount of 30 grams of total fiber per day is my general recommendation for everyone, except for in very limited circumstances. But those are the recommendations. And then they transition into eating that way over 4, 6, 8 weeks, whatever it takes, because it's about developing new dietary habits and eating to sustain and promote health for the rest of their life, not just a fad diet. And so here's a summary here. Osteoporosis, it's under-recognized, under-screened for in gastroenterology. The underlying pathophysiological mechanisms and medications, those are the common causes of secondary osteoporosis. And the underlying mechanisms include chronic inflammation, hyperpermeable gut, nutritional deficiencies, dysbiosis, and the clinical recommendations. The old, you may have heard of it, 4Rs in terms of the intestinal dysbiosis, kill the bad stuff, remove, rebalance the gut microbiome, reinoculate with healthy gut bacteria, and then repair the intestinal lining. Mediterranean diet with ample fiber and protein, identify and supplement with nutrients to correct for deficiencies, and to supplement with those nutrients shown to preserve bone mineral density and reduce fractures, and protect against medication-induced bone loss by decreasing medication when possible, discontinuing them when possible, or switching to safer ones. If you have any questions after this, there's my direct email. You can also reach me through my website. A lot of articles, and this research is on there as well. And
great as always, John. Thank you, John. I don't even have, there's not even one question in the chat. I think you covered it all.
Well, I hope that means I did a good job versus people went to sleep during it.
No, I don't think anybody went to sleep. Dr. Neri, you got anything online?
Yeah, you suddenly got a chat question there. You want to get that first, or should I go?
What can you say about FMT? Is that
fecal microbial transplant? I think it's an exciting area of research. I think it hasn't been shown yet for osteoporosis, but I do think it's an exciting area to watch.
Okay. Is there a risk for fracture effect from SSRIs and the way 5-HTP the way there are with SSRIs?
There does not appear to be. And there's no research with that conclusion, but I've talked to some experts in gastroenterology who are also experts in nutritional medicine, like Eric Yarnell, if you know Dr. Yarnell at all. And because of the way that the 5-HTP is metabolized, because of negative feedback loops, he's not concerned of it at all, and I've never seen any research that's problematic. I personally prefer L-tryptophan supplementation, because the rate limiting step in the conversion of that pathway down to serotonin is the conversion of L-tryptophan to 5-HTP. So even if there is a theoretical risk of that with 5-HTP, that would obviate it through that negative feedback of that conversion to 5-HTP.
Okay. Dr. Freeland says I might have missed it. D3 with K2, okay?
So yes, that actually is good, and it depends on the type of K2. The research supports MK4 plus D3. So there are clinical trials of MK4 45 milligrams per day with D3 showing, not with fracture outcomes, and the studies are primarily in postmenopausal women with osteoporosis, but the improvement in bone density in the patients taking the 45 milligrams of MK4 with D3 was significantly greater than the patients taking MK4 alone. In the study that combined MK4 with D3, that I shared, there was also a greater improvement or preservation of bone density than in the patients taking the MK4 or the D3 alone. And you also do not have the increase in serum calcium that occurs with the D3, that can occur with D3 alone.
Dr. Newstad, I think the hype about MK7 came from the conversation of the cardiovascular outcomes because of the matrix GLA protein, so that it would prevent the calcification of arteries in relation to cardiovascular maintenance. So, but now I'm understanding that MK4, if you want to focus on bone health, that's a better form of MK to use. Is that correct?
That is correct. I have a whole presentation, CE talk, that I gave on clarifying the vitamin K confusion, that reviews all the studies on MK7 and vitamin K1 and MK4 for cardiovascular health. And so, yes, to answer your question directly, MK4 is the nutrient, and for the dose of 45 milligrams per day, that is most supported by the research for bone health when it comes to bone density, but more importantly, fracture outcomes, maintaining bone strength. Now, comment just briefly on what you said about matrix glycoprotein. That's a surrogate marker. And I think it's important for us all to just be very careful of treating surrogate markers and instead of looking for the clinical outcomes that we're actually trying to prevent or reverse. So what we see in the clinical trials with MK7 and coronary artery calcifications is that there's no consistent benefit. There was only one study, in one study where it was helpful at slowing down coronary artery calcification, not reversing it, was in patients that already had a coronary artery calcium score above, I think it was above 400. I'd have to check on that, but they already had coronary artery calcification above a certain threshold, and only in those patients did it slow it down. More consistently in different patient populations, and the vast majority of those studies have been conducted in patients with kidney diseases. But more often, what we see, even if there's not an improvement in coronary artery calcifications, is an improvement in pulse wave velocity, that arterial distensibility improves. And you see that there are more studies with MK7 when it comes to cardiovascular health. Most of them were negative. So no association with matrix glycoprotein and the clinical outcomes they were looking at in most of those studies. No association with PIVKA2, for example, a vitamin K dependent protein, and the outcomes in those clinical trials. With the MK4 study, you did still see an advancement or a progression of coronary artery calcification, but that progression may have been slowed because it was actually at a lower rate than that sort of background expected rate in the general population. But it was a poorly designed study. And I think with the MK7, and I think those claims that are being made by dietary supplement companies in terms of clinical outcomes are premature. And I don't think the published research supports those health claims.
So by itself, MK4 can definitely stand as a standalone for osteoporosis prevention, or is it always needed to be combined with vitamin D?
It doesn't always need to be combined with vitamin D. The research with MK4 45 milligrams per day showed that by itself, it can be very helpful at improving bone density and maintaining bone strength. And but also what we see with the vitamin D is vitamin D at a serum concentration of 30 to 44 nanograms per milliliter is associated with the maximum reduction in hip fracture risk. And you do see synergistic benefits in terms of even greater improvements in bone density when vitamin D is combined with the MK4.
Okay. There's a question about BPC 157, 500 milligrams twice a day. I'm taking that's the oral form.
I don't know anything about that. I've seen it advertised, but I don't know the research on it.
Yeah, there's some GI, upper GI calming effects with the BPC. So it's intrinsic factor, I believe. It was actually discovered by Pavlov in 1904.
Intrinsic factor, which is for
Well, it was
B12 absorption.
It was he didn't know exactly what it was. It wasn't identified till about 10 years after his death, and it wasn't really isolated as BPC 157 till 1993.
That's interesting.
So the oral form is useful for a GERD, upper GI inflammation. The injectable form is more for we use it for joint pain and localized inflammation. So.
Yeah.
And
also for leaky gut, I heard for leaky gut, it's also good. Yeah, decreases inflammation and it's good for the brain too, for the nerves, and promotes angiogenesis.
We use some other peptides for that. It certainly wouldn't hurt.
I think peptide therapy like FMT is a promising area. I've not seen much research on it. but I think there is one study in, this is not peptide theory, but exosomes in rats that showed improvement in bone density. I think that these areas of research are very exciting. I just have not seen
Yeah,
outcomes in
we've
humans.
used peptides in our practice for almost 20 years, and we've had very good success with it. And we actually added the BPC to the GLP-1s 4 or 5 years ago when we first had them compounded and we started doing the mini doses, and we had
Well,
really great
I'm talking just for bone health. I don't,
bone health, right?
that's
Right.
all
Yeah.
I'm,
Mhm.
my comments are very narrowly focused on
Okay.
that. I don't know
All
about
right.
it.
I won't go off on that tangent then. Dr. Nario, do you have any email
Yes.
questions?
Yeah. So this is a good question for, I mean, I'm curious about it because DEXA scans, as you said, it sounds like it doesn't give much credibility to where your real BMD would be. It's almost like late stage. And there now we have what we call bone turnover markers through blood. So this
Yeah.
would be your serum CTX, P1NP. Where does this stand in terms of how do we use this clinically? Because we know that Medicare probably wouldn't pay for your DEXA scans every year. I think every 2 years, and they have specific, I guess, requirements
Yeah.
for you to get it if you defy those every 2 years, like low body weight, prior fracture history, smoking. So where do you stand on the recommendation for clinicians in the use of these bone turnover markers?
So if this group is interested, I do have another talk all on CE talk on testing, on and osteoporosis testing, and
What are you doing in November?
coming back here. So here's my take on any of the testing. The greatest value, doesn't matter what the test is, in my opinion, the greatest value of any of the tests is to raise awareness and open the conversation, because the major risk factors for fractures in osteoporosis are not directly related to any tests. So there are only two bone turnover markers that are recommended by the International, Society for Clinical Laboratory Chemistry: CTX and P1NP. Those that's it. And there's a lot of challenge when it comes to those bone turnover markers, and there are a lot of them. There's analytical variability. So the coefficient of variation for some of the tests, intra-assay can be 15, 20+%. There's time of year has an effect. So bone turnover is greater in the winter than in the summer. So if you test bone turnover markers in the winter and you compare it to the summer, well, they're going to be probably going to be higher because just natural annual fluctuations. There's diurnal fluctuations, which is why we test it in the morning, fasting. If somebody's had a fracture in the last 12 months, bone turnover markers can be elevated. If they have any systemic sclerosis going on or systemic connective tissue disorder, then the bone turnover markers can be elevated. There are no outcomes data showing that just changing a bone turnover marker reduces fracture risk. What I use them for clinically is more to help patients stay motivated and engaged in their own healthcare. Because, like I said, for me, the best value is whether or not of these tests is to raise awareness for patients. So as you correctly pointed out, Dr. Nario, that the testing for bone mineral density test is only every, maybe 18 to 24 months, typically. And so those the bone mineral density changes are going to happen over a much longer period of time, whereas the bone turnover markers will change much quicker. And by the way, you can have the CTX, for example, bone destruction happens much faster than bone creation. So you can have that bone destruction, the CTX increasing over the course of a few weeks, whereas it's going to take a few months for those bone turnover markers to come down. So you can or for those bone anabolic markers like P1NP to go up. So I would test if really I give a patient an option if they want to know. Like I can give collagen, MK4 and vitamin D3, hydrolyzed collagen. Those have all been shown to reduce CTX and P1NP. So we can do that. But then you're looking at other markers. Look, MK7 will probably bring down CTX, but MK7 does not improve bone density, right? It's never been shown to reduce fractures. So again, we're talking about a surrogate marker and how much weight do we put into a surrogate marker versus the real clinical outcome. What does the data show in terms of fracture prevention? And it just doesn't support, I change one turnover marker and suddenly I'm getting this magical reduction in fracture. No, it's diet, sleep, exercise, stress reduction, dietary supplementation, getting risk factors of destroying bone, removing them. And then those for me at least, the bone turnover markers and any other testing is just there to help people stay motivated or that show they're on the right path, because people do want to see something. It does help them having a number on a test, and I understand that. But clinically, they're not as valuable. The research does not show that they are as valuable as most clinicians with whom I talk claim they are. And I'll give you another example. I've had some clinicians talk about using the ratio of bone turnover markers to predict whether somebody is a fast bone loser or a slow bone loser, whether they're losing bone quickly or slowly. And I had a patient come to me just totally freaked out, completely anxious. They were told that they're losing bone quickly because of the ratio of their bone turnover markers. That analysis, the research shows, is no better than a flip of a coin. It can at telling people whether they're losing bone quickly or slowly. And I think it's doing a disservice to patients and creating anxiety for something that they really can't control very well, and telling them that they're losing bone quickly when literally it is no more accurate than 50-50 of whether they are losing bone fast or not.
Right. And that's the problem with these testings. There's so many external factors that can determine the outcome of these tests. And even it's almost like HSCRP. You have another inflammatory area of your body and you test it, and that also is definitely not going to be accurate. So as you said, yeah, we definitely need to back it up with studies that fracture risks really going down if we correlate it with that.
I do like you mentioned CRP. So I do think in terms of value of testing, like CRP, just like with PSA for prostate, it's more the delta, the trend over time that I think is more important than any one specific test result.
Right. Here's one. So we're all hormone users here, or aficionados of hormones. So I've always heard of this, that estrogen helps with osteoporosis. Can it stand alone in terms of treating osteoporotic patients, or should it be something preventative, or should it be with bisphosphonates, without bisphosphonates? What is the more effective approach with estrogens?
So estrogen is FDA approved for the prevention of osteoporosis. The research shows that in perimenopausal women starting hormone replacement therapy, that you can get a 28% overall. It's associated with a 28% overall reduction in osteoporotic fractures. If they start at 60 years or older, there's no data that it's beneficial. So really starting at perimenopause seems to be the most beneficial time period. I don't know of studies that have looked at that sort of nuanced of a question or tried to answer it. Bisphosphonates plus estrogen, without estrogen, and comparing the two. I can tell you as a standalone, for the primary prevention of osteoporosis, bisphosphonates do a horrible job. So the vast majority of the studies out there are for secondary fracture prevention. For primary fracture prevention, what you see with bisphosphonates is about a 43% relative risk decrease in vertebral fracture risk, but no hip fracture risk reduction. The problem is that about 70% of bisphosphonate users discontinue after a year, 60-70%. Because it takes 80, you have to take the medication 80% of the time to get the benefits. So you've got a majority of the patients, or maybe it's like 60%, stopping, discontinuing after a year because of the side effects. So the medication possession rate for bisphosphonates is quite low. So the number, when you look at these very contrived clinical trials, and where controlled, very strict inclusion, exclusion criteria, the researchers looked at a series of patients coming into their medical clinics years ago and compared those to the inclusion and exclusion criteria of, I think it was 4 large osteoporosis drug clinical trials. And the vast majority of those patients, very few of them, I should say, would have actually been included in those studies. So the real world application of these bisphosphonates do not correspond to the patient populations that were treated. And what we see in the real world, and there have been some meta-analyses have done that looked at the real world use of these, is that they don't actually work for the primary prevention of both vertebral and hip fractures. So they're not as useful as I think a lot of people are, expect them to be. For secondary prevention, they're better. But if you look at the absolute risk reduction with the bisphosphonate for vertebral fracture, for example, it's about 1.1%, the absolute risk reduction. So, take that for what it's worth.
Yeah. And then also when in the use of estrogen, I've seen studies that I think more of the backing in literature is related more for, we use a lot of creams. I mean, we compound, but really the studies are behind the recommended FDA forms, such as the patch, or they have oral estrogen also. So that's why I think one of the questions here was, what about studies about, estrogen creams? I think that's what I can contribute to that. But on your end, what can you say about that specific question?
I don't have a lot to say with respect to bone health and bone density. What I do know is that for hypoarousal syndrome, disorder in perimenopausal women, no libido, also women experiencing decreased, cognition, decreased mood. There was a 4-month study that was done using transdermal estradiol, and it did show, I think it was 52% of the women improved had significant improvements in their libido, a little lower percentage in mood, and still significant, but a little lower percentage in cognition as well. I don't know of clinical trials with fractures or bone density specifically with that.
Right. Here's I don't know
if we're still on hormones, can I just mention male osteoporosis and hormones for a moment?
Oh, sure. Definitely. We like that.
One of the things clinically that I see missed a lot is that men are not getting their estradiol tested. So it's the testosterone is, converted to estradiol, and it's the estradiol that is, primarily responsible for maintaining bone density and bone strength, both in men and in women. So looking at the testosterone as well as the estradiol is important, and then modulating the testosterone so that it stays in the physiological range, but also to ensure the estradiol is above 20 seems to be the optimal for male bone health.
I think Dr. Bill has, he had encountered this in your lectures, right?
We know all about that. We've had a revolution in estrogen and and aromatase, using aromatase inhibitors in the last 2 to 3 years. And also, Dr. Neri, you should know, and we do not use oral estradiol.
Oh yes, but those are just
right. You mentioned it though. Well, that's one of those almost nevers.
Yes.
So.
Okay. Here's a curious question. So calcium, we always hear about controversies about it. Don't take it because it's going to be something bad for your arteries. It's okay if you're osteopenic. It's okay for prevention, calcium by itself. Just take it when you have osteoporosis. What's your final take on calcium?
So I think that it's over supplemented. I think that, and when it is supplemented, I think that it's oftentimes too high of a dose. The current position statement of the Bone Health and Osteoporosis Foundation and the American College for Preventive Cardiology is that calcium up to the limits set by the National Academies of Medicine of 2,000 to 2,500 milligrams per day should be considered safe. The challenge is that most people are just giving blanket recommendations of 1,000 or 1,200 milligrams, or still I've even seen 1,500 milligrams of calcium as a supplement to their patients, when really we're talking about calcium from all sources. So that total amount of calcium, the USRDA of 1,200 milligrams per day in women and 1,000 milligrams per day in men, is from all sources, diet plus dietary supplements. The average American woman consumes about 800 milligrams of calcium in her diet per day. So if just the average American woman, if you don't want to take the time to really try and calculate precisely how much calcium she's getting, a dietary supplement with 400 milligrams per day of calcium is considered both safe and would get her into that range of 1,200 milligrams per day, USRDA range. Above that, there's no improved benefit for bone health, but still be nowhere near any toxic range. For men, the average American man consumes about 1,000 milligrams of calcium in his diet per day. So for the average American man, they really don't need calcium as a dietary supplement. Now, the important thing with calcium is that it also needs to be there for the bone benefits with vitamin D. So, I never look at calcium alone. I'm always wanting to test vitamin D and then supplement as is appropriate.
Yeah, are you a big fan of the citrate, like
I am.
Common citrates?
Yes, calcium citrate is my preferred form of calcium because it is absorbed in a basic pH, in a more basic pH. Hypochlorhydria and achlorhydria are more common with patients as they age, with patients with GI conditions, autoimmune diseases, obviously on acid blocking medications as well. And so with those patients, calcium citrate, you'll get the absorption, but also if somebody has oxalate kidney stones, it's the citrate form that is the recommended form, that does not increase the risk of oxalate stone formation.
So does it matter if it's hydroxyapatite or those higher types of calcium, or citrate can definitely get you by?
So it depends on what we're talking about. So if you're talking about fractures, there's no indication that one form of calcium is superior to another form when it comes to fractures. There's also no indication that one form of calcium is superior to another form when it comes to bone density. So I look more at absorbability, GI tolerance, safety, kidney issues, and that's why calcium citrate for me checks all those boxes.
Right. Okay. So this is my last question on my list. So you mentioned about GLP-1s a while ago. So GLP-1s has been noted to produce sarcopenia. Are there studies that have also been affecting bone as well? So this is something harder to assess, because sarcopenia, we can assess that through calipers, through observation, even the weight loss. But how about bone? Is that something getting affected by these wonder drugs out there?
So I looked at that a while ago. It's been a few months. At that time, the research showed no effect on bone.
All right, that's good. So that's not part of that weight loss then.
So commonly what we see with people with obesity, when they lose weight, they do lose bone density because they're oftentimes on a hypocaloric diet, right? And so, but once they stabilize in terms of their caloric intake, and they get to that weight, the bone density tends to go back up. But the GLP-1s alone by themselves, are those causing bone loss? To my knowledge, the current evidence is saying no, but I think that needs to be studied more. But currently, I think the answer is no.
Well, thank you, Dr. Neustadt. You got all my questions out of the ballpark here. Home runs.
Thank you.
Yep. Couple more here. So what about intranasal calcitonin?
I like intranasal calcitonin for people with vertebral fractures, healing from vertebral fractures. Other than that, maybe as an adjunct, it's been many years since I've used it. And it's been primarily in that situation of just, healing from a fracture.
Okay. And then there's a question about magnesium, boron, zinc, and strontium.
So I go back to the question. So I view all of every, whether it's a drug or dietary supplement, through the lens of, has it been shown to reduce fractures in prospective clinical trials? That's the bottom line. If it hasn't, well, has it at least been shown to improve bone density? But as we know, bone density does not equal fracture reduction. There's not a one-to-one relationship there. There doesn't necessarily equal fracture reduction. Magnesium, zinc, copper, boron, none of these have been shown to reduce fractures in clinical trials. There is I think it was the North American Menopause Society updated position statement on osteoporosis, and they mentioned magnesium in there, and a study from 1990. And this is where, going back to the primary data, I really encourage people when they read a review article to pull up the primary studies, because oftentimes the primary studies are misinterpreted and misquoted. And an example of that is this magnesium study from the 1990 that gave magnesium oxide. It was shown to improve bone density, but it's been misquoted as being shown to actually reduce fractures, but it was underpowered to detect fractures. So that's the only study on magnesium as a dietary supplement. Magnesium intake from food has been shown in studies to have an association, and other studies to have no association with bone density. And there are no studies looking at fractures as an outcome. So in the studies with the MK4, we're talking about over 70% reduction in fractures. There was no other magnesium, copper, zinc, any other nutrients given except for vitamin D and calcium in some of these studies. So that's where I land on that. With boron, it's interesting because that boron became popular because of a study that showed that there was increased calcium excretion when boron was low. But what was missing from that analysis is that happened only when magnesium was also low. So, all these, treating just based on associations, I think is a slippery slope. And you've got a lot of supplement companies that have everything but the kitchen sink in their product, because it changes a molecular marker, or because there's some association with calcium excretion. Well, calcium excretion in the kidneys does not necessarily equal osteoporosis. And so I look for fracture outcome data. Strontium does have fracture outcome data on it. There are only 4 nutrients, actually, that have fracture outcome data in it in prospective clinical trials: calcium and vitamin D, MK4, and strontium. Strontium, every study on strontium was done as strontium ranelate, which is a medication in Europe. There are 5 or 6 large clinical trials in Europe on strontium ranelate. All but one show that it only prevented vertebral fractures, about the same as an oral bisphosphonate like Fosamax. And there was no hip fracture prevention. Only one of the studies showed hip fracture prevention, so it's questionable whether hip fractures are actually prevented. Now, in the United States, strontium ranelate is not available. It's available as strontium citrate, the dietary supplement. There are no clinical trials, 0 clinical trials on strontium citrate for efficacy and safety. So what these companies are doing, and we can do the same thing, is, okay, let's assume that the strontium citrate is equivalent to the strontium ranelate. So we have to just, I think, be very honest of what we know, what we don't know, and what we're assuming. So we're going to assume that the strontium citrate is equal to strontium ranelate. So what we know is that it definitely can reduce vertebral fracture risk, maybe reduces hip fracture risk, but the majority of the data showed that it doesn't. This is in postmenopausal women with osteoporosis. But what we also know is that it gives false bone density test results. So strontium is a mineral. It incorporates into the bone, and like calcium, and these X-rays bounce off the minerals, and that refractive index, that angle at which it bounces off, that's what's detected by the machines, and it works its magic and spits out the T-scores and Z-scores. And in Europe, because it's a medication, they can correct for that. In the US, we don't know how to. Those machines don't do it. Radiologists don't know how to do it. And so the bone density test results are inaccurate. Now, I despite the limitations of the bone density test, I do want them to be accurate, the ones I'm looking at. But again, that's not as important as the fracture reduction. So assuming that strontium citrate is as effective as strontium ranelate, we're getting about the same fracture reduction as Fosamax. But what about safety? A lot of these companies, unfortunately, and I think it's disingenuous, are saying, well, it's just as effective as the strontium ranelate, but we're going to say that it's safer. without any data. So I think that's disingenuous. What did the safety data show for strontium ranulate? Well, what the safety data show is that for every one fracture that was prevented, it caused a blood clot that can produce a heart attack or a stroke, a DVT. For every one fracture that's prevented, it's potentially killing somebody else. And so they actually require, or it's recommended to have, thorough cardiovascular risk screening before prescribing that medication. In Europe, it was taken off the market in some countries for a while. And in the US, people are just taking the strontium citrate as a dietary supplement, no screening, no safety data on that form of strontium. And also because it gives false bone density tests, it's also not as effective as what we've seen with MK4 and the combination of MK4, calcium, and vitamin D. And for those reasons, I'm just not a fan of strontium. And if anybody wants all those studies and summaries, it's in another presentation I've got. I'm happy to send you those slides. I've got all the citations. I've got all the PDFs. If anybody wants more information, really about anything that I've said, just let me know. I'd be happy to share it.
Yeah, we'll after we turn off the video, we'll get your website up here. Somebody asked about chondroitin sulfate.
I don't know of any research on bone health for that. I've never looked either, but I don't. What I can say is there's no fracture studies on it, because I have searched PubMed and Google Scholar for, nutrients, nutritional medicine, fractures, osteoporosis. Yeah.
Mm-hmm. Okay. That's pretty much all I have here. And any final word there, Dr. Neustadt?
Look, I think that ultimately it's this holistic approach gives superior results. And like I mentioned before, so much of fracture risk is independent of tests, and the tests are important, but it's one small piece of a larger puzzle. And the more we can empower patients to make those changes in their lifestyle and health and things that have been shown to reduce fractures, the healthier they're going to be, not just for bone health, but in all domains. Everything that I've talked about in terms of diet, I didn't even talk about sleep. I didn't talk about exercise and the research on that. They also reduce the risk for cancer and cardiovascular disease and dementia, and on and on and on.
Right. Okay. One last question from me.
Yes, sir.
What went wrong with the bisphosphonates? So back in the day, when they first came out, I was in a real medical doctor group, the insurance base, and you had certain criteria you had to meet, and one of them was almost as soon as they came out, if you had a perimenal or postmenopausal woman and you didn't order a DEXA scan and treat with the bisphosphonates, you were in the bad category. So where did they go wrong?
So it actually dates back, I think, to the history of osteoporosis and how it was defined. So osteoporosis in the 1940s, there was a doctor at, I think it's Massachusetts General Hospital, that removed the ovaries from pigeons and saw the bone become more porous. He termed this less bone in bone. And so that set the stage, and that was through an X-ray. So that set the stage for bone density ending up being the diagnostic criteria for osteoporosis. That definition was codified, formalized in the 1990s by the World Health Organization as osteopenia being a T-score of -1 to -2.5 and osteoporosis of -2.5 and lower. And so it became the focus, not just of diagnosis, but insurance reimbursement. And now with things moving towards health outcomes types reimbursement, that marker, that bone density, it's even more entrenched in the conventional paradigm of osteoporosis, of changing that marker. And the bisphosphonates, the assumption was if we improve bone density, well, we're treating osteoporosis. We're improving osteoporosis, and we're reducing fracture risk. Well, the bisphosphonates showed that they improve bone density, but then more research started coming out looking at fractures and fracture risk. and showing that, yes, for secondary fractures, they can prevent, they're fairly good at preventing secondary fractures, but not as good for primary fracture prevention. And, I think where it went wrong is just this, then you've got this whole medical, legal, healthcare association, clinical guidelines, everything based on that foundation of that study from the 1940s. And that's a very difficult cycle to break.
Yes, another one would be that testosterone causes prostate cancer. That also came from a report in the 1940s. That's
Correct.
another story. That's another story.
Correct. Or Forteo increases the risk for multiple myeloma. That came from a couple of rat studies where they gave like hundreds of times the dose of what any human's ever been. There's a black box warning now on it, and yet millions of doses have been given out, and studies have looked at this, and there's no risk in the real life use of Forteo of bone cancer.
All right, everybody. Thank you so much, and we'll see you again next time. Same time, same station. Dr. Neustadt again. Great talk as always, and we hope to see you soon. I'll see you at AMMG definitely, and hope to hear from you sooner.
Look forward to it.
Good night, everybody.
Thank you.
Thank you.
Thank you.